well, I'll say who I am. I'm Jon Emery. At the moment I'm based at UWA, but I'm just sort of moving across to Melbourne as the new Professor of Primary Care Cancer Research at Melbourne, and I'm still working as a GP and will be once I get here.
Great. Well, this evening really is an opportunity, I think, to go through some of the clinical components of this familial history cancers project, and to go through, I guess, the origins of the tool. And I think we've got a mixture of practices here that are partaking in either method 1 or method 2, which is a great mix to have rather than all being one. So in terms of, I guess, the data collection, it's a good opportunity maybe to have a chat in terms of, we've spoken and have provided a copy of the template, but if there's other ways that people have got thoughts as to how that data extraction can occur, very happy to have that discussion as well. But in terms of any clinical questions you might have, Jon's certainly here to help facilitate or answer any questions you might have regarding a positive answers to any of the questions itself. So I'll hand over to Jon, and just to let you know, the presentation is being videotaped as well, and will be uploaded, I think, on Wednesday onto our website. So if you wanted to refresh your memory, or the presentation also will be on our website as well electronically for you to access.
Great. Okay. Thank you very much, Amanda, and thanks so much for you all coming out this evening. As I say, we've been discussing this project for a few months now, so it's nice to see it coming to fruition. I'm going to be really talking to begin with just a bit of background about family history and its importance as a risk factor for cancer, and then go on to why we're thinking about screening for people's family history and the justification for doing that. And then a bit about how we've gone to develop this family history questionnaire and some of the research that's led up to showing that this is actually a valid tool to be using. And then go on to the details of this project and what it will mean for your practices. And then some time to obviously take questions. So really this is just to reflect on the history of the family history in general practice, really. This is, I really like this painting. This is a Rockwell painting, and it's sort of that beautiful historic view of what general practice is about. It may be not quite as family-centred as this picture is all the time, though traditionally we've known our families very well. Obviously with more movement, then we tend to know the family histories and our families of the patients that we see less well. Family history as a tool in general practice has got a wide range of uses, really. Historically, we've used it quite a lot as a psychosocial tool when people come to understand actually some of their concerns about the symptoms that they're presenting with. But gradually it's being recognised as an important use for assessing risk of common disease. And particularly as we've been unravelling the genetics of common disease, it's still actually seen that the family history is probably better than a lot of the genetic tests that are currently available. That will change, but it's still always going to have an important role in assessing risk. And so as we move towards that more tailored approach to disease prevention, the family history is going to be an important part of that. So I'm going to now just provide a quick summary of the evidence about how well family history predicts risk. And so if we start off with breast cancer, these are just the relative risks for somebody who's 60 and who has a first-degree relative with who was affected at the age of 60. But you'll see essentially as younger age of onset and multiple relatives are affected with increasing risk. And that's common for most of the cancers that we'll be discussing. But so age of diagnosis is very important as in adding to that risk. And 11% of women who are diagnosed with breast cancer will have at least one first-degree relative of breast cancer. Similar story with prostate cancer. If your father was diagnosed with prostate cancer above the age of 60, that still doubles your risk of getting prostate cancer. The risks seem to be slightly stronger if it's your brother rather than your father. And particularly if they're below the age of 60, the estimates are up to 4-fold risk if your brother was diagnosed before the age of 60. And then if you've got 2 affected first-degree relatives, the relative risk goes up to about 5. For colorectal cancer, again, age of onset and multiple relatives are important. So if you're a 50-year-old and you have 1 first-degree relative, then that more than doubles your risk. Then if you actually have 2 first-degree relatives, then again a 4-fold increase of risk. And up to 20% of people with colorectal cancer will have an affected first-degree relative. And then finally, melanoma. Again, 1 first-degree relative almost doubles your risk. And 12% of people with a diagnosis of melanoma and 20% of those with multiple melanoma will have an affected first-degree relative. So that's just a quick summary of the sort of epidemiology. The other important thing is that there are some relatively rare but important genes that have been identified and for which predictive testing is currently available. So BRCA1 and 2, which have been known about for about 15 years now, and predictive testing is offered to high-risk families, and that's associated with very early onset breast and ovarian cancer, and risks of up to 80% if you carry the mutation. Lynch syndrome, which is a syndrome predominantly of early onset colorectal cancer, but this cluster of other cancers as well, so endometrial, ovarian and gastric cancer. And again, genetic testing is available for people who have these more complex family histories. This is an example of a family history of these types of high-risk families. This actually is Paul Broca's area, the neurologist. This was his family history. And as well as writing all about structures in the brain, he wrote several books about familial cancer syndromes in the background of this sort of a family history. It's almost certain that they had a mutation in BRCA1 or 2. So when we're thinking about screening, obviously there are a number of well-established criteria as to why we might consider offering screening. First of all, is it an important health problem? Cancer is now the leading cause of disease burden in Australia. It accounts for about 20% of the disease burden, and there were 108,000 new cases in 2008 of cancer in Australia. If we look at more local data, within this Medicare local, it's now the highest cause of disability-adjusted life years. And then there's this other attempt to get a handle of the importance of prevention, that within the North and West Melbourne region, these are the estimates of avoidable cancer deaths. So 721 avoidable colorectal cancer deaths and 502 avoidable breast cancer deaths. We know also that family history is an established risk factor, as I've just discussed. And then a lot of people will question, well, just how well do people know their family history when they come to see you? And there have been a number of studies looking at this very question. People are actually quite accurate, particularly about their first-degree relatives of common cancers, up to 93%. It's slightly better for breast cancer than it is for abdominal cancers. And then again, even for second-degree relatives, pretty good accuracy actually. And there are ways within practice that you can use that we'll talk about to actually improve that self-reported accuracy. And then, of course, we need to actually have some interventions to offer people once we've identified that they're at increased risk. So, if we look at, first of all, breast cancer and primary prevention, there are a number of strategies. There's growing evidence now for the role of certain drugs in preventing breast cancer in the both moderately and high-risk groups. And tamoxifen and raloxifene are now recommended by the MBOCC as an option for women who are at moderate or high risk of breast cancer. People who are BRCA mutation carriers are often also the option of risk-reducing surgery. Both mastectomy and oophorectomy will be discussed. And again, for the broader group of women, there are obviously important lifestyle risk factors, age of first child, breastfeeding, exercise, a number of things that can be discussed. In terms of secondary prevention, of course, there are various range of screening tests available. Mammography is the one that has the best evidence, of course, and that's part of the National Breast Cancer Screening Programme for women aged over 50. But as we'll go on to see later, there is advice around earlier use of mammography with or without ultrasound for women who are at moderate to high risk. And then for the very high risk, MRI is probably a better test and is now funded through Medicare. In terms of colorectal cancer, there's a really interesting story about aspirin growing, and you may have seen some of the reports in the last couple of years about the role of aspirin in reducing mortality from colorectal cancer from a number of the aspirin trials, and they've reanalysed them looking at cancer. The best evidence is for colorectal cancer, but it appears to actually have an effect across a range of different cancers. And there's a similar effect for COX-2 inhibitors as well. And again, there are broader lifestyle risk factors in terms of diet, particularly reduction in red meat, alcohol, and smoking are all risk factors for colorectal cancer. Again, we have good screening tests for people who are at increased risk. Colonoscopy is the screening method of choice, and then the identification of polyps and excision of those polyps has been shown, particularly in the higher risk populations, to dramatically reduce their risk of bowel cancer. For melanoma, of course, we've got the classic slap-slop approach. And also there's a role for both self-examination and surveillance of lesions, particularly in those high-risk populations, and a growing interest in the role of sort of self-monitoring, potentially with various imaging devices. Prostate cancer, of course, is a little bit more controversial. There have been some early trials to suggest that 5-alpha reductase inhibitors, things like finasteride and duosteride, reduce the risk of prostate cancer. It's not yet licensed for that purpose, but there is interest in that as a potential primary prevention strategy. And then, of course, we have PSA and DRE as a screening test. And we have a paper that's due to be published shortly showing that PSA screening becomes more cost effective the more you limit it to high risk men. And so that again there's a sort of rationale for thinking about the role of these types of prevention in people who are at higher risk. So I think hopefully I've persuaded you that these are some of the important criteria that are met around the family history. But then you also need a suitable screening test, and you also need the screening test to be acceptable and that it won't cause significant psychological harm if you start using it. And that's really where some of the work that we've been doing, both at UWA and in collaboration with colleagues in Cambridge, to develop a suitable screening test for use in general practice. And so what we aim to do is to develop a family history screening questionnaire and then actually test how well it performed in patients recruited from general practice to identify those people who are at higher risk of a number of common chronic diseases, and also to look at the psychological impact of having your family history screened. So this was just some of the first questions. There were 16 questions that we began with, and we actually, while we're focusing today on the cancer-specific questions, we also tested questions relating to ischemic heart disease and type 2 diabetes. And we had some additional questions relating to certain ethnic groups who are increased risk of specific conditions. So, for example, within the family history of heart disease, we included Afrikaner and Lebanese because they have a much higher prevalence of familial hypercholesterolemia. So this was a paper-based, self-completed family history questionnaire. We started off with 16 items, and the precise wording, we'd gone into a lot of trouble to get very simple wording that made it very clear about the types of relatives that we were asking about. And they were developed following a review that we took of all the previous studies of various family history screener instruments that have been used in general practice. And so what happened, we invited people aged 18 to 50 from a number of general practices in Perth, and they completed this 16-item family history questionnaire. And then a trained genetic counsellor took a detailed 3-generation family history. And that essentially formed the gold standard collection of their family history. And then that was used to assess their risk for the various conditions, based both on the RACGP Red Book criteria, and where there were more complicated family histories, we had a clinical geneticist review those pedigrees to determine a risk. And then they were followed up really for, the PIQ is the Psychological Inventory Questionnaire, which was looking at anxiety and any effect it had on various behaviours. So, I'm going to now just focus on the cancer questions. And this is just to show you the prevalence of people who are at increased risk. So we recruited just over 500 people into this study. And you'll see that there are 9% increased risk of breast cancer, 6.9 ovarian cancer, 6.5 colorectal, 5% prostate, and 10% were at increased risk of melanoma. To give you a feel of the sorts of numbers that you might expect. Now some of those there'll be overlap, particularly with the breast and ovarian cancer, but it's not with the other groups. And then we were interested to see if we could actually get a shorter set of questions and how well they actually performed. Now, you have in front of you the final version, just so that you can understand the questions and how they relate to this table. So the very first question is, do you have any close relatives who've had melanoma? And what we mean by close relatives are essentially parents, children, brothers and sisters. And so for melanoma, that had a 92% sensitivity and 81% specificity to identify people at increased risk of melanoma. The next question 4, which is the prostate cancer question, again performed pretty well, 83% sensitivity, 98% specificity. The false positive rate is just to give you a feel for we got very few false positives as a result of these questions, and so in the context of the work that we're proposing, very few people who will be invited back in to have a more detailed discussion of their family history will be false positives. They will very likely have a significant family history. And then the next questions, you'll see that we looked at a number of different questions to see how they worked both individually and in combination. So question 2 in our list here is, have you any close relatives had bowel cancer before the age of 55? And that on its own only had 44% sensitivity and 95% specificity. The second question, yes, which is, do you have more than one relative on the same side of the family with bowel cancer at any age? And this broadens it out to second-degree relatives as well. That alone, slightly higher sensitivity, pretty good specificity. But if you combine both those questions, so answered yes to either of those, you increase the sensitivity but maintain a pretty good specificity. And similarly with ovarian cancer. So question 5, which is, have you any close female relatives had ovarian cancer? Question 7, which was actually a question around breast cancer, but of course the combinations of breast and ovarian cancer are very significant. And so separately 46 and 98 and 43 and 90%, but combined as 2 screening questions for ovarian cancer, then you up the sensitivity without major loss of specificity. And then finally with breast cancer, there were 3 items. So have any of your close female relatives had ovarian cancer? Have any of them had breast cancer before the age of 50? And do you have more than one relative on the same side who has had breast cancer at any age? And that's the question that includes second-degree relatives. And you can see that the combination of those three questions gives you very high sensitivity and pretty good specificity for identifying people who are at increased risk of breast cancer. And then we looked at what happened to the people who've been identified at increased risk and compared to those people who were told that they were average risk. So those who were identified at increased risk, they were more likely to seek further information about their risk. They were more likely to consult somebody to discuss that and to find out about further tests. They were more likely to change their diet and become more physically active, but no actual difference in referral to a specialist. So most of the further tests could be managed at a general practice level in this study. So that's the basis for the questionnaire that we're going to be using in this at North Melbourne Medicare Local Project. And so I'm now going to talk a bit more about this. So essentially what we're doing, we want to pilot two different approaches to implementing the use of this family history questionnaire in general practice. We want to see how easy it is to use and how easy it is to integrate into routine practices, and see how acceptable it is both to patients and to the practice as a whole. And we're really interested in those issues about feasibility as well as its impact on identifying people at increased risk and referrals for people at increased risk of cancer. So I'm going to talk you through this because this is essentially the nuts and bolts of how we see it working. Now you'll have in front of you these, which are the information sheets for patients. And then they will have, with this, the family history questionnaire. And there are various different translations. So we've got it in
Arabic, Turkish, and
Italian.
And potentially Somalian as well.
Okay. So if we start in the top left, there are basically two approaches that we'll be testing, and there'll be just one specific approach in each practice. And so one option is completion in the waiting room, and there are various degrees, I guess, and this is where we need to get feedback from you as to how you think this might work best, as to whether it's just on the side in the reception area, whether or not your receptionists actually specifically hand it out, and so we're interested in how you think it might work without having too much of an impact on the routine flow of patients through your practice. So it's an approach to offering this to adults who, while they're sitting in the waiting room, and completing it there. The alternative is to have a pile on your consulting desk, and then it's at the discretion of the GP or practice nurse as well to use and to offer to go through the questionnaire in the consultation. And so we're testing these two different ways to get an idea about which is going to be more practical.
Sorry, John. Is everyone aware of which method hopefully you'll be using as part of this? Just touching this, yeah? No? You will be method 1, which is completion in the consultation room.
We decided on the waiting room, is that right?
Yes. Yeah.
Everyone else happy where they
We're in the waiting room.
You're in the waiting room? And what are you in?
Waiting
room. Okay. So we can talk more about this at
consultation.
Okay. So we've got some in each group,
Yeah.
That's good. And so the patient will complete this. If they've got all no's, then so there will need to be some process for a GP to review the questionnaires, or potentially a practice nurse again, and that's up to each individual practice to work out how fine detail of this will work best for you. But there needs to be some formal review of each completed FHQ. Clearly, if they've all ticked no, then that's straightforward, and they will be clearly not at increased risk or average risk. The family history questionnaire needs to then get filed in their record, and they need to be coded as no follow-up required.
So just talking about the coding, I think everyone, Tim, have you got, what software have you got? You have got medical, so has everyone got medical director? Yeah? Yeah. So in terms of the coding, is everyone comfortable with how we're going to code that, or just a clinical note in the as you would normally enter? Yeah, beautiful. So I think some of this will come out of the reporting. Just in terms of if you're seeing a patient in response to, even if they've got a negative to the questions, that there is documentation.
Just in the notes.
Just
not
in the
one
notes.
place to put it in, it's wherever you want to put it in.
So we might come on to this in a bit more detail further on, actually. Yeah, but the coding is one of the really important parts of this that we'll come on to later on. If they tick just yes to any single box, then actually that means that they require an additional review of their family history. And so they will need to be some mechanism to following them up and organising a second appointment and coding that as follow-up required. And then they need that follow-up appointment booked, and at that appointment, and again it's really up for a discussion within the practice as to how best this is going to work, whether you have a small number of clinicians doing this detailed risk assessment, or whether it's done by each individual practitioner. But essentially within that consultation they need to have a more detailed family history taken, and I'll go on into the details of that in a moment, and then they'll be managed according to the current RACGP Red Book guidelines. There will be a small number, as I talked about, there will be a small number of false positives, but we have designed the questionnaire to keep those false positives as really quite low. So there will be a small number who will actually, when you take their family history in more detail, that they actually will be deemed at average risk according to the RACGP criteria, and you can reassure them and advise them on the preventive strategies consistent with that level of risk. For those that are increased risk, again it's a matter of referring, managing them according to the guidelines that I'm going to go through in more detail in a moment, and that may be referral or organisation of additional screening tests. Any questions about that? No? So, in terms of taking the family history, this is the really important part of this. This is just a screening tool, and in order to be able to categorise people into a finer level of detail about their risk, then they need a 3-generation family history taken. So that is all first degree and second degree relatives, so grandparents, aunts and uncles, on both sides of the family, and that's particularly important even for breast cancer. Breast cancer can be inherited on the paternal side as well, and so a complete 3-generation pedigree on both sides of the family, including issues of ethnicity. So it sounds like you have sort of more Turkish and Italian, so not many Jewish families in this area, but so the ethnicity is probably less relevant in this part of Melbourne. Just to say, Jewish ethnicity is probably the most important one in terms of risk in the context of cancer. Ashkenazi Jews, which are really Eastern European Jews, have a much higher prevalence of BRCA1 and 2, and that's why we specifically asked for it, because it increases their risk of breast cancer. Age at diagnosis for each cancer is important, and often there will be some uncertainty, but try and get an estimate at least to within 5 or 10 years, and most of the guidelines are within those limits, but that will help, as I say, refine the risk assessment. And then try as much as you can to clarify uncertainties around the diagnosis. Stomach cancer can essentially mean any intra-abdominal cancer or liver mets, and it's sometimes going to be difficult to really refine that. You can ask patients to do some further homework, either before they come in for their risk assessment, or if there is uncertainty, to ask them to go back. There will often be somebody in the family who knows the family history much better, and trying to go back and get further information if there's enough uncertainty that would make a difference as to what you're doing and what you would recommend is worth thinking about. That said, if people who are potentially at high risk, and if you refer them to a family cancer clinic, then they will actually do their best to go back to the original pathology to confirm the diagnoses and age. So that's something that obviously is beyond what we can do in general practice, but if it does sound like a bowel cancer or a gastric cancer, then assume that was the case, and it will be checked. Now I'm going to now talk a bit about the latest version of the Red Book. This was published towards the end of last year, and there have been some minor modifications to the risk assessment, and so as it relates. Now I don't expect you to see this in detail, but just to flag that you will all be given summary copies of the Red Book criteria for the cancers that we're covering. For breast cancer, it categorises women into 3 levels of risk, so average, moderate and high risk. With the family history questionnaire, essentially what we have tried to do is the cut-off between average and anyone at increased risk. So within the people who answer yes, most of them will fall in the moderately increased risk, but there will be some who fall in the high risk group that I'll come to in a moment. And the importance of that is obviously the screening criteria and recommendations are different if you're at moderate versus high risk. And so about 4% of the female population are at moderately increased risk of breast cancer. And the current recommendation is that they may well benefit from earlier mammography from the age of 40, particularly if they had a first-degree relative diagnosed before the age of 50. These are the high-risk criteria. So these are people who come from families who may have an underlying BRCA1 or 2 mutation in the family. They are obviously much rarer. The recommendation is really to refer them to a family cancer clinic, and they will then have a more detailed risk assessment process, again with confirmation of the pathology and a specific management plan discussed and the various options for managing their risks, as well as discussion of the potential for genetic testing. In terms of ovarian cancer, these are the Red Book guidelines, which really are, I think, the main take-home message, I think, for these is that screening, there is no good screening test, even for people at high risk at the moment. And so don't go ordering CA125s or transvaginal ultrasound scans, because most of the trials, even in high risk women, haven't shown that to be an effective screening test. If they're in the high risk band, then they will meet the criteria for high risk of breast cancer as well. And so it's probably best to refer them to the family cancer clinic, where a discussion of both their ovarian and breast cancer risk will be undertaken. They may, for example, require obviously additional breast cancer screening and maybe also colorectal cancer screening too. Just to flag that the National Breast and Ovarian Cancer Clinical Guidance, which is now under the auspices of Cancer Australia, actually have slightly more detailed management guidance around people at potentially high risk of ovarian cancer. But they essentially have very similar high-risk criteria, and really the bottom line message is if they meet the high-risk criteria, then the family cancer clinic is the place to refer them. You may also want to know that on the Cancer Australia site there is actually an electronic family history risk tool for breast and ovarian cancer. you may want to at least have a look at it and see whether you think this is something that you might find useful as part of this detailed risk assessment. Alternatively, as long as you've taken the detailed family history and you're happy going through the risk criteria that we'll summarise from the Red Book, then we're not saying that you have to use this, but you may want to at least have a look at it and have a play with it to see if it's something that you might want to use. These are the criteria for melanoma. So as you'll see, at increased risk in the moderate risk group are just a single first degree relative with melanoma. And again, that's really the advice, of course, is slip, slop, slap, but also an examination of the skin. If they've not had one done, then you may want to organise a total body skin check, either at that visit or on another visit. Probably another visit will be more convenient. And there's not very clear guidance as to how often you should then continue to do that, but certainly an annual basis would not seem unreasonable. For the high risk, these are people who have a family history or a personal history, but have multiple atypical or dysplastic nevi. And these are the people who require more frequent examination of the skin, possibly with or without photography of specific skin lesions. Prostate cancer, obviously we could spend all night talking about PSA screening, but these are the latest Red Book guidelines, which have been somewhat controversial. For the average risk men, then the recommendation is to only respond to any issues that are raised by the patient, and not even to raise PSA screening unless men want to clearly talk about it. The high-risk men, again, are consistent with our criteria, so a first-degree relative. They've actually increased the age to 65. When we produced the family history questionnaire, 60 was the cut-off. So they've upped the age limit a little bit. And then obviously the very high-risk people are from families with BRCA1 or 2. I think these are the group of men who we know from other studies are more interested in a discussion around PSA screening and the pros and cons of PSA screening. And so that would be certainly highly appropriate to talk about when they might want to consider starting PSA screening. The Australian and New Zealand urology group, of course, talk about a single PSA test at the age of 40 to get a baseline risk. It's confusing both to GPs and to patients, this having different guidelines around PSA testing, but in the context of high-risk men, certainly a discussion around the uncertainty, the fact that there are trials which do show a mortality benefit of early detection in a group of men from 55 to 69, but that there will be a lot of men who will essentially have treatment and get all the consequences of that treatment for cancers that wouldn't necessarily have actually caused them any harm, and that's the difficulty, of course. Colorectal, in a way, is much easier to talk about than prostate cancer. We have very clear guidelines about different categories of risk, and again, this is the reason for taking a more detailed family history, because we need to distinguish those who are moderately increased and those who are at high risk, because the screening guidance is different. So those who are at moderately increased risk, so one first degree relative before the age of 55, or two first or one first or one second degree on the same side at any age, they're the main criteria for moderate risk. And they should be offered colonoscopy every 5 years from the age of 50, or if they had an affected relative before that, then 10 years earlier than the earliest age of onset in the family. And you may want to also be offering FOBT testing in between those colonoscopies. The high-risk families, these are people who have family histories consistent with Lynch syndrome or familial adenomatous polyposis, which is a much rarer type of inherited bowel cancer. These are the detailed criteria, essentially for people with possible familial adenomatous polyposis, they require screening from a very early age, so from their teens. It's a very rare condition though. Lynch syndrome would be offered colonoscopy from the age of 25 every 1 to 2 years, and again possible genetic testing. So these again, like the breast cancer families, are best managed within the family cancer clinic. These are the local family cancer clinics. The closest one to you is at Austin, I'm guessing. But there's also one at Petermac and the Royal Melbourne, and also Monash Medical Centre. Patients can actually self-refer, but obviously in the context of this study, then this will be the referral route for the high-risk families. So I guess the importance of actually part of the discussion today is thinking about how this will work in your practice and getting systems set up in your practice to make that whole flow of patients through this study, and also how the data will be managed as well. And so really it requires the whole practice to know about the study, and a whole team involvement to really make this work well. Thinking about the family history questionnaires to begin with, for those in the waiting room, clearly the reception staff are all going to need to know about these questionnaires, because they may well be getting questions about them. And having a clear process for where they're going to be, ensuring that there are enough available, dealing with the requests for family history questionnaires in different languages and so on. In the consulting room, and again ensuring that all the doctors in the practice know about what this project is about, and I guess having a discussion around the completion of the family history questionnaire and how that's actually going to work in the context of routine consultations. And again, having a process to ensure that there are always enough of these available in each consulting room. You'll need to set up a process of who's going to be reviewing all these FHQs and then following them up and organising the follow-up appointments. And again, each practice will probably want to do this in a slightly different way, and so it'll be a matter of working out within your practice what system is going to work best for you. There needs to be clearly a process to follow up those who have had a positive FHQ, ensure that they get adequately followed up and come in, or at least offered an appointment to have their family history assessed in more detail, and probably a process for recording those who actually decline not to come in for that appointment, so that it can at least be flagged on their notes when they come in any time. And then you need to decide within the practice exactly who will be conducting these more detailed risk assessments, ensuring that they're familiar with the risk assessment process and the follow-up for people identified at increased risk. Deliberately not trying to be prescriptive about this, because I think you all need to think about these different issues and how it will work within your practice. Data management, though, is a key part of this, as we were just starting to talk about earlier. Each family history questionnaire needs to be numbered, so that's one method that we can be trying to get a count of how many family questionnaires have been handed out, how many have been used, and so on. And then there need to be a range of different codes that can be entered into Medical Director, so that how the people have flowed through that pathway, so that we can actually count the numbers in each different part of that pathway. So there needs to be a code for a negative family history questionnaire where no follow-up is required, a separate code for a positive family history questionnaire where follow-up is required, then a code to show that family history assessment appointment has occurred, and then the ability to identify which were identified at increased risk and which were at average risk. And Amanda, you can talk more about the support for that in a moment. And so essentially what we eventually want to be able to do is calculate the number of family history questionnaires that have actually been completed in the practice, and then the number of patients who are identified at increased risk as a result, and what happened to them as well. So the numbers of referrals, ultimately we'd like to know the outcomes of those referrals, and we also want to have during this project the capacity to provide you feedback on how you're going, and so that the capacity to conduct some of the audit of the numbers sort of midway through this, so that you can get some early feedback as to how things are going. And so the idea is to run this, well, correct me if I'm wrong, Amanda, is to run from April to June, that's right, isn't it? 30th of June? Oh, wait.
April, May, June, yeah, in July.
Yeah. And there will of course be support from the Medicare local project team for the practice. As I say, it would be good if we could get run the initial audit of the data collection and provide you feedback as to how many patients you're seeing and so on. And with final data collection running through to August, is that right, Amanda?
Yes.
And Amanda again can talk about practice remuneration issues if needed. So it's now your opportunity to ask any questions that you have.